All right then, let's get started. So, as I said, page 139, cellulitis. We're going to start with uncomplicated cellulitis. We're going to talk a little bit about then complicated cellulitis, recurrent ulcerations associated. We're not going to deal with the diabetic foot though, because that's really a separate category. And then we're going to talk about neck fasc. I will just put a teaser out there by saying that over the 24 years that I've been faculty at LA County, I would say that no disease has been more present at Morbidity and Mortality Conference than neck fasc. Now, part of that is the county hospital population, as I've already alluded to, with a lot of homeless and indigent people. We also have a disproportionate amount of drug abuse and IVDA, and so all of that's part of it. We also have a tremendous amount of alcohol abuse with liver disease, and I'll touch on why that liver disease is important for some of the cases. But among these cases, the outcomes are terrible, and death really is part of the outcome spectrum for neck fasc. With neck fasc, if you have it on a part of your body that can't be debrided or amputated, you're in real trouble. Real trouble. So when you look at the people who die, if it's their axilla or groin and the neck fasc extends onto their trunk or abdomen, they're in real trouble. They're in real trouble. And the surgical procedures associated with these are really sort of horrific, long cases in the OR with them where the surgeons keep asking if we're done with the debridement and keep having to extend. And, the junior surgical assistant is picking off little dead bits of necrotized fascia. And these are horrible, long cases that often go way further than the surgeon thought they would on the initial planning, and they are associated with a distinctive stench wafting down the hallway of dead flesh. So we'll get to that in a moment. Let's start with uncomplicated cellulitis though. So abstract one talks about this. So no diabetics, no HIV, no complicating features of such as abscess or necrotic areas. And this was done at Olive View Medical Center, 180 patients in 2010. The years are important because you want to know if there's enough MRSA in the mix for it to be relevant now, because the incidence of MRSA keeps increasing. Having noted that, what these papers say is that uncomplicated cellulitis is not an MRSA disease. It's strep. Yes, if there's an abscess under it, and that's why finding that abscess is so important, because that really changes the spectrum of disease. It's much more likely to be MRSA. If there's no abscess, if you look at this paper, serology was positive and cultures were positive for 73% of the time for strep. Uncomplicated cellulitis is strep. If you found an abscess in it, which is what abstress 2 talks about, then you flip the numbers. Now it's 64% MRSA. Peds, abscess, abstract 3, if there's an abscess, 71% MRSA. No abscess, likely strep. And so that's where this whole thing of taking an ultrasound and poking around and looking at it and asking yourself, is there a fluid collection, really changes what you're worried about. Abstract 4, I was happy when I first saw the title, I was like, oh God, please don't tell me this worked. Because I remember when I was a medical student and an intern, whenever we had these cellulitis patients, I remember a senior resident telling me to get a needle, a small syringe, and inject a little normal saline at the leading edge of the cellulitis and make an intradermal pocket and then aspirate it back, and we'll culture that up. We'll find the organism, like the organism was surfing on the front edge of the red. They were all out there catching the wave. And it never seemed to work. And I was like, why do they make me do this? The patients hate me for it. And we never seem to get anything, and we seem to totally ignore it. And so they looked at this needle aspiration, looking for what the organism was. This was 20 kids in Baylor in Texas, 14 of them who need to be admitted. They injected a half cc, they aspirated it, they put it in culture bottles, and 3 out of 20 were positive. Those were MRSA, even though most of the other kids turned out to have strep. And they said that this was extraordinarily low yield, and I was happy to find that, because the idea of returning to what I sort of instinctively know from actually doing it was useless, was shown to be useless. So that made me happy. The 2014 Infectious Disease Society recommendations and guidelines for cellulitis and what antibiotics reflect what I just said. So if you think it's mostly strep and it's a mild cellulitis, they recommend Pen-VK, Keflex, Diclox, Clinda, other cephalosporins, even ceftriaxone or cefazolin, and that's fine. If it's a moderate cellulitis, and they don't do a good job of telling me what the difference between mild and moderate is, for some reason Diclox is no good anymore. I'm not exactly clear on the way, but I'm just the vehicle that is reporting what they say. And they still recommend mostly anti-strep. But if you go to abstract 7, you'll find something that you hear, and probably some of you are already doing. I know some people at our place are doing it, and I certainly have done it as well, that if you see an abscess, if you see a cellulitis, and you're worried, as we are in our institution, because MRSA is really, really a dominant organism, you might say, well, it's cellulitis, so I should give the Keflex for the strep, because that's really good. And maybe I'll add some Bactrim just to cover my bets in case this is one of the rarer ones. And so in abstract 7, they compared that, and there was no difference in outcomes. So they sort of say, well, go back to just the straight up one drug therapy. But I'm still okay with that personally, and certainly in our institution where so many of these are MRSA related given the population. That's, I think, a reasonable strategy. I've heard Greg Moran, who's an infectious disease expert at Olive View Medical Center, talk about this, and he also doesn't have a big bone to pick. If you want to do the Keflex Bactrim thing, that's fine. if you look at the 2008 paper number 5, I'm backtracking a little bit, and they looked at beta-lactams versus non-beta-lactams. They found not much difference in terms of rates of return ultimately for an IND. And abstract 6 says even when it is MRSA, if you give the wrong abscess, the wrong antibiotic, they do better, unless, of course, there was an abscess there, in which case they come back for an IND that wasn't done up front. Abstract 8 is a 2010 paper from Hawaii, and we're going to talk a little bit about this stuff. Are there any issues that come to mind if I said we're dealing with a Hawaiian population? Thank you. So right up front here, I get this Polynesian Samoan population, and why does that become relevant here?
I work in New Zealand. We have a lot of...
Thank you. We're going to get to the New Zealand paper. So we got a Kiwi up here who's going to tell you, so tell me more.
For some reason, they're very sensitive to staph.
So they're across, and she's exactly right. For those of you who didn't hear, they seem to just get staph. They seem to be practically defenseless against it. They also have a high diabetes rate. They're also big humans. There's an obesity issue amongst much of that. We know that obesity is a contributing factor in some of these infections. And so you got to be really careful. In that population, there just is if you're seeing that population, Samoan, Philippine, Polynesian, what's the tribal group called down there in your islands? The Maori. You really got to be thinking about staph. That's just what they get. And so that's a little bit different group, and they tend to get bad infections. They don't do well with them when they get them. So you really want to get it right the first time when you're dealing with those. So if you saw that population with a cellulitis, I'd be giving Keflex and Bactrim. I certainly wouldn't leave the MRSA uncovered under any circumstances. Yeah, they don't have much MRSA in New Zealand yet. I have a Chilean colleague. They don't have much MRSA there yet, but I've been going to Chile enough to bring it. They will soon. They will be calling me the fomite. All right, so in this Hawaiian population, Bactrim was the highest success. No surprise given what I just told you. There are some other unique immunocompromises among that group, while we're on this, sort of talking about, and they're not well understood by the infectious disease community. But for example, the Filipino population is tremendously susceptible to coccidiomycosis. If a Filipino Los Angelino drives from LA to San Francisco with the window open through the Central Valley, they'll have cocci when they arrive. I mean, they just will. So there are these weird sets of immunocompromises that you'll see in that Pacific Islander group. And so you have to consider that when you see these infectious disease papers coming out of those areas, you have to understand that's a different thing. Yeah, I'm sure Eskimos are probably more similar genetically. Do you work with that group?
I did.
She did. All right. Yeah, I did a little work in Alaska. You fly in, you know you're nowhere when the airport you land at is named Dead Horse. Yeah, I flew into Dead Horse. Yeah. And there's no, it's terrible. You know, you get up there, you're like, well, people when they come out of their houses up there, all the houses are built up on struts because if they build them on the ground, they melt the permafrost and they sink. So they all have to be up on struts. But when people come out of the houses, they look under their houses like this to see if there's a polar bear underneath there. Because the polar bear sort of learned, you just wait underneath here and a delicious warm thing will come down the stairs. Yeah, it's a weird place. All right, 9 is a cost analysis paper. It looks at some things like what the Red Book, you guys know what the Red Book is? It's sometimes also called the AWP, the average wholesale price. So it uses those prices to do a cost analysis, and it says that Keflex is cheaper than Bactrim is cheaper than Clinda, and so that if you were really thinking that you were in the strep world, then the Keflex would be substantial savings. And in this study, they come out saying Keflex might be good for some of it, but they did have 27% MRSA, which is way low compared to my hospital, way low. And even with that number of MRSA, when they did their cost analysis, they said Clinda, which covered both, was the best. I talked about the inducibility of Clinda, so you have to be aware of that. And even at Clinda, which is almost twice expensive, $396 in this analysis versus $175 for Keflex, the Clinda won. Now I list those prices, and I just have to warn you that they may not be what your patients are charged. You really have to find out. Even pharmacies next to each other can be hundreds of dollars different in the same neighborhood. And that's why the other name for the Red Book, the average wholesale price, the AWP, is referred to by many pharmacists as the ain't what's paid book, because the prices are all over the dartboard. All right, that takes us to abstracts 10, 11, and 12. And because Vanco is really, if you had an MRSA and it was complicated and you needed to give IV antibiotics for it, and you felt you needed it, you would be giving IV Vanco in that setting, right? And IV Vanco, there's really oral Vanco just isn't that readily prescribed, so you have to admit them. So this created an opportunity for the drug industry, the pharmaceutical industry, to come up with alternatives to admitting them, like a drug that you give one dose of that has a half-life of a week, and they can come back in a week and get their next dose. And so that would save a hospitalization theoretically. And so, even though those drugs are not that expensive to make, what did the pharmaceutical industry do? They priced them competitively with admission. So you have these drugs, Orbactive, which is Oritavancin, and you have Dalbavancin, and those are abstracts 11 and 12. And these drugs, and Cubicin and these other things, these drugs are all priced at around $3,000, $4,000, $5,000 a dose. Holy shite. So whatever savings you were hoping on getting from admitting them to the hospital, they'll almost all be eaten up by drug costs. Many of these studies, since these are new drugs, what kind of studies do you expect these to be run by the drug companies? Non-inferiority trials. So they're going to do a non-inferiority trial versus vancomycin or linazolid, which are both the sort of out there drugs, and say that our drug is just as good. No need to be better. We're going to save you the hospitalization and a little bit of money, but not much. And so, in abstract 10, which is manufacturer sponsored, they're going to look at Oritavancin. For those of you who have a little Spanish in you, I like the Orita. Right now, Vancin. Orita. So, it's going to be very popular in Latin America, obviously. Oritavancin, this drug has a half-life of 7 to 8 days. And it's approved by the FDA now. And they compared it to 7 to 10 days of Vanco and did this weird cost analysis where they said, of course, their drug would save you money in the long run because you didn't need to hospitalize. 11 is a New England Journal study looking at Vicuron is the brand name for dalbavancin. This is a drug with a half-life of 8.5 days, and it had a 91% MRSA cure rate. And they point out that the adverse drug reactions were less than vancomycin. Vancomycin, as you know, when you give it, people get itchy skin. It's a cause occasionally of red man syndrome, right? We talk about red man syndrome with vancomycin, and Dilantin are the two main drugs that cause red man syndrome. And there was less nausea, vomiting, diarrhea, and pruritus. So they said, geez, look at how great our drug was. Saved hospitalization, less drug reactions. For just a few $1,000s, you could have all that. And again, abstract 12, where in that paper, MRSA was 57% of the patients, and the cure rates for dalbavancin were comparable to linezolid. For what that's worth, and I already know people who are doing this to avoid hospitalization, it certainly makes sense, but I think the cost of these drugs is outrageous the way they came up with them and priced them. All right, what makes a recurrent cellulitis? How many of you have seen someone who came back who you IND'd, or someone in your group IND'd like 4 weeks ago, and now they got another one, and they're really frustrated, or it's the third one? When it's the third one, you know, they're at the height of their festivity. They are mad. They're like, Jesus, what's going on? And they're doing things, and these are people who are colonized, who are getting these recurrently. They may have had a vestibulitis, and sometimes you'll see your colleagues in the healthcare environment who've had a vestibulitis or something on the back of their neck, or right now I'm struggling with a blepharitis that keeps coming back, which is probably MRSA. If you'd like me to share with you, I can. You can bring it back to your hospital. When you see those kinds of things, those people get recurrent abscesses that are MRSA related. And so what's the IDSA definition of recurrent? It's not the second one, it's the third one. So 3 to 4 events annually they consider recurrent. And at that point, you can consider prophylaxing them with erythro, IM benzathine pen, minocycline, doxycycline, something like that, and worry about it. You also might consider some of that kind of prophylaxis behavior if they have other problems. And when you look at the underlying condition that causes a cellulitis, I find this interesting. What's the most common underlying condition? If you were to ask, what's the root cause? You got this calf cellulitis. What's the root cause? Tinea pedis, athlete's foot. So fissuring of the skin is how the bacteria got into that space and got there. There are other, diabetes and obesity, big conditions with this. HIV, venous insufficiency, eczema, all sort of ways to have breakdown in skin and increase your risk for recurrent infections. All right, that takes us to the neck fash papers, and we're going to talk more about the traditional causes of neck fash, not the unusual ones. Let's just bang out just so we know the story. You're a patient who's a diabetic, maybe you have liver disease from too much alcohol, you have some portal hypertension, and you decided to have oysters raw when you were in New Orleans. What are you going to get? So that person comes in with a cellulitis that looks necrotizing or hemorrhagic or bullous, and they're going to have Vibrio vulnificus cellulitis, and the reason they neck fash, and the reason they have that is because the way you clear Vibrio, when you eat oysters, you get Vibrio. There are 30-something species of Vibrio. They're in all oysters. So it's not like you got the unlucky oyster. All oysters have Vibrio species in there. So you eat them, they get into your GI tract. A few of them might cross the tight junctions, but whatever bacteria get out of your GI tract into your portal circulation are heavily opsonized. Your immune system is like, what the hell is that? It recognizes it for sure. So they're all coated with antibodies and opsonized maximally. The problem is that you need Kupffer cells to clear them from your circulation. And so if you have liver disease and some blood doesn't go through your liver, it goes around it, you're in big trouble now. Because now these things are going to get to the other side of your circulation and you're going to get neck fash. So that's one that's out there. You were in fresh water, it's going to be Aeromonas hydrophila. You got like something like an alligator bite or a turtle bite or something like that. And then there's the Clostridia species which are in there, which also have sort of specific stuff that go with them. Having noted that, let's get in there. Abstract 14 from New Zealand, a Kiwi paper. 48, most were Pacific Islanders. They found strep as the major cause, but mixed organisms in a third. These patients had lots of OR time and averaged 4 surgeries. As I said, these are horrible cases. They had long lengths of stay, like 31 days in hospital while they did multiple. They had bad diabetes, bad obesity, and this other mystery immune feature. At Diane Birnbaumer's hospital in West LA, they also see this Samoan population. And so that's going to come up in Abstract 16, which is a Harbor UCLA report, where you might think, oh, this is an American population. No, a bunch of those in that series of, I think it was 14 neck fasc. Do you know exactly how many were Samoans die? Like, what? Yeah, but it's like a third probably, or something like that. So even that paper relates to Abstract 14 because there's a Samoan population in West LA. And then Abstract 15 is a Philippine paper, which reminds me, so in that paper, half were E. coli. What does that mean to you? That's a comment on the plumbing in Manila. So I was told, I remember when I was in medical school, I was told this. This has to do with the fever and the traveler thing where I said Hep A is the most vaccine-preventable cause of death. And I was told this in medical school. Outside of the United States and a few countries in Western Europe, but by no means all of Europe, the world is covered with a fine patina of feces. And that's exactly what you're seeing there, is the reflection of that fine patina of feces in their soft tissue infections, where 44% is E. coli, and other fecal organisms were 15%, like Enterococcus. Staph was only 15% there. So neck fasc, if it's on, what do we know about neck fasc in terms of finding it and stuff? So that's going to be the next thing. I mentioned that this ends up often in M&M conference, and the reason is because someone looks at these cases which have horrible outcomes with amputation, these debridements, these disfiguring surgeries, or death, and they want someone to be responsible for that. And so they pick the case apart, and they'll say there were delays in diagnosis. There were delays in consultation of surgery. Surgery didn't believe that it was neck fasc, so their delays were going to the OR. There were transfers involved, and now they have this horrible outcome, and somebody's going to pay. We're going to look for somebody to pay because the outcomes are so bad. It is primarily outcome that drives med-mal in the United States, and these outcomes are bad. So if you wanted to pick it up earlier, what could you do? So we got a couple papers to talk about that, and let's just go over the things that I think are important. The first thing is, any cellulitis that you see that hurts too much, you ought to think that's not a regular cellulitis. So if they have poop, and poop, pain out of proportion, comes up over and over again as emergency medicine, as something that you ought to respond to with more curiosity and workup. So if they have belly pain and poop, you're supposed to think ischemic bowel. If they have a fracture and poop, you're supposed to think compartment syndrome. If they've got a cellulitis and poop, you should think neck fasc. If they have pain out of proportion, you got to respond to that. The next thing is, you're often labbing these people up. And this combination comes up over and over again in these. A white count that's a little higher than you thought. There's a cellulitis brewing, maybe something in the axilla, and the white count's 26. You're like, holy shit, look at that. I mean, I'm not surprised it's high, but 26? You're thinking, that's generous. 26. And then the sodium's low. Not really low. It's not like it's 119, but the sodium's low. It's 131. It's 129. And so over and over again, this combination of a high white count and a low sodium, you have to, when that thing appears, even just a little bit low sodium, you ought to be thinking, wonder if it's neck fasc. If it progresses rapidly, we see some of these cases progress right in front of us during their ED course. You send in the resident or somebody goes in with a marker, the nurse marks the edges. You come back later, you're like, that's not the edges, the edges over here. No, that's where it was. Whoa. That's neck fasc. And many of these people require advanced imaging, but people get blamed for doing the advanced imaging because it's delaying the operative intervention. How many of you think the advanced imaging is actually delaying the operative intervention? I don't. I believe the advanced imaging was being used to convince the consultant that, I'm sorry, Holmes, you actually have to go. Look at this shit. It's going everywhere, and it's nasty. And so the advanced imaging is often talked of as a delaying feature. So 17 looks at the increasing CT use in neck, fascia, skin, and soft tissue infections, and increasing MRI use too. They note that in 294 patients back in 2003, that not many of them got imaged, and a lot more of them got imaged in the later years, and that the mortality was increasing. I can't say that that's due to the imaging, that's just association. And so they say that imaging costs are increasing and that the imaging had little overall benefit. I think that's hard, again, to conclude. These surgeons are, like I say, these are horrible cases. They're trying to figure out, where are we going? If it's in the groin, am I going to need a urologist? Are we taking the scrotum off or not? Real question. It's in the upper arm. Are we going into the trunk? Should I have a CT surgeon around with us, a chest surgeon? I don't know. So I think that this assumption that they don't need imaging, I got it. It's a delaying feature, but I don't think that's the main problem. The main problem is it's a really bad disease. Modern concepts in neck fascia is abstract 18. It says that many cases are even considered to appear trivial. I saw a kid, and this kid had a horrible outcome. I was called over to our PEDS by the pediatricians. Take a look at this, Billy. What do you think? And there was a kid there who looked sick. Not obviously toxic. I will note they did not have a fever. And the kid had what looked like, if I had been writing with a sketch pencil and had the graphite all over my hand, had two sort of smudges right here of that sort of gray look. And we were like, are those fingerprints? Is this an abuse thing? They didn't look obviously like a bruise. I palpated. There was no crepitance. There was no. This kid had truncal neck fascia, did horrible. That's what it looked like. Two smudges. No fever. Like, if you want to talk about what was the big delay, no, it wasn't obvious. Comment.
It often doesn't look like anything. I saw one.
Yeah.
Outcome sheet, no redness, nothing. Just horrible pain and a horrible pain.
So the reason it doesn't look like anything is because not primarily spreading on the skin level, it's spreading on the fascial plane. And so that takes you to whether ultrasound would help with diagnosis of this, and I think it does, but you have to be pretty experienced with it. So our residents will put the probe over the red part, and you'll see cobblestoning and signs of cellulitis, and maybe some fluid along the fascial plane. But if you go where it's not red and there's fluid along the fascial plane and some cobblestoning around that, that means that the infection is spreading deep, not superficial. And so we'll look at them from that standpoint. The L-Rinic score is talked about here. That's called the laboratory risk indicators for neck fascia. Some authors say it's good, some authors say it's bad. I already distilled out of it what I think is the most important thing, which is, like, would you be surprised if they were a diabetic and they had higher sugars? No. But would you be surprised if they had a low sodium? Maybe. And so it's the low sodium and high white count. 18 is a paper that talks about modern concepts in neck fascia. Diagnosis and treatment, says that MRI is the preferred imaging if you are going to go for advanced imaging, but don't delay. If someone's ready to go to the OR, as I was once told by my chair, if a surgeon wants to go to the OR with a patient of yours in the emergency room, your job is to help them leave. There's no point in discussing it any further. Put the oxygen tank on the thing. Get the thing. Can I put a lid on your coffee? What can I do to get you and that patient out of here? Anything I can do to help you? There's no discussion about, well, I don't know if he needs to go to the OR right now. No. Or maybe we should go to, no. Just help them leave at that point. In that paper, they say delayed debridement causes increasing death, torso involvement, increasing death, bad host factors, obesity, diabetes, immunocompromise, increases death. They say that you should use Clinda on these, and we do at our hospital, because it may suppress toxin synthesis by some of the underlying organisms. So whatever you're starting, consider, on a case like this, consider adding Clinda, because it'll look like you were on it. And physical exam misses the diagnosis. Abstract 20 talks about hard and soft signs. And the hard signs, as you pointed out over here, sir, are often absent. I think anyone can make the diagnosis when they got hemorrhagic bulli and bronzing and crepitance. It's not hard there. And pain out of proportion. But a lot of these, when they're early, they don't have much to go on. You're just like, what's wrong with this person? They're acting worse. 21 says the Elrinic score is great. 23 notes the Elrinic score. It's not so great. I think it's worth being aware of it. Why do I like the Elrinic score? Is because sometimes the patient has a score of 7 and the surgeon doesn't believe me. So I'll just print the paper out and say, Elrinic score greater than 7, we better be worried about neck fasc. It's not that I really believe the Elrinic score, but when it's positive, and it's greater than 6 is a highly predictive of neck fasc, then I'll present that to them. And I got 2 more here at the end, or 3 more. 26 says if you transfer them, that delay is going to increase death. But I don't think that's fair either. You're in a small community hospital with no urologist. This is a 6-hour case. You're going to kill that person's next day. These are complicated. They're going to need an ICU care, maybe hyperbarics, who knows. I understand the instinct to transfer that. So, I think you got to look at, sometimes they need pediatricians, urologists, CT surgeons, so I think we got to be a little more permissive of that. And then 24 and 25 say, look at hyperbaric oxygen. It's very clear that hyperbaric oxygen before the surgery, that's not going to work. They need to be debrided, maybe after the surgery. So I'll let you think about those. And there's some summary recs down there that say that, if you want to do the Keflex Bactrim thing, fine. That really emphasize that if you're thinking about neck fasc, at least consult the surgeon early. If they say no, I don't think it's that, at least you called them early. If it turns out to be that and you didn't consult them, they'll say, what do they say when they get consulted late? Of course I would have taken them to the OR earlier if you'd called me. No, they wouldn't have. The Harbor series that I quoted, that one paper in there from Harbor UCLA from Diane's place, they noted in that paper that 8 or 9 of those 14 cases were not considered to be serious problems when they were first consulted. It was not, neck fasc was not suspected by the surgeon called to the bedside. And that's frequently the case here. So this was, just understand when you're having this question that if you have a conflict with your surgeon about the need for debridement, that's par for the course. And that's why there's more imaging, because you're trying to move on and prove it.